Oh. Good morning, Chào Boi Sang, as they say in Vietnamese, and it's my pleasure and honor to be here. I've been to Ho Chi Minh quite a few times, but it's my first time to Hanoi, and it's a beautiful city, also with beautiful people. And I'd like to thank Besan for giving me this opportunity to be with you this morning in the presence of your prestigious professors, Tien and Mimi. And I hope that at the end of the morning, we will all go home with updated information and a firmer conviction to manage our menopausal women, especially here in Asia. So the title of my lecture is How to Optimize the Safety and Efficacy of Menopausal Hormone Therapy with Transdermal Estradiol. So this is my disclosure. I'm an associate professor at the University of the Philippines College of Medicine. I'm also the current president of the Philippine Society of Climacteric Medicine. And Professor Tien mentioned that Vietnam has no menopause society yet. So I hope that you will join us. So the Philippine Society of Climacteric Medicine is an affiliate society of the International Menopause Society. And we're also a member of the Council for Affiliated Menopause Societies. And we have other Asian countries which also have a menopause society. So I hope you join the club. Okay, so I speak for these some pharma companies. So just a brief review. So we now know that the life expectancy of the woman has been longer. So we live longer now. So in the 70s, usually the olden times, right after birth, we die, right? Women die. And then in the 60s in the Philippines, 70s, the life expectancy was 65, and now it increased to almost a decade, 75 years. Okay, so in industrialized countries, it's approximately 78 to 86 years of age in European countries, and it's predicted that by 2025, 1.1 billion postmenopausal women will be worldwide, and that 1.3 million women will enter this stage annually in the United States. So if you imagine, almost the women live more than a third of their lives in the menopausal years, right? So if we get to menopause, in the Philippines, the average age of menopause is around 48. Caucasians, the average age is around 50. I think you also have your onset a little earlier. So if you can imagine a Vietnamese woman being menopausal in her 40s and she gets to live another 30 years, then you don't want her living with a diminished quality of life. Okay. So now we discuss menopause in the new era. So many women spend, like I said, over a third of their lives in the postmenopausal state. And this coincides with the period in the women where some of us are in the peak of our careers when we reach menopause, isn't it? So some now modern women also postpone their pregnancy such that even at a not so young age, they get to have children which are still young. So again, the emphasis on managing these women. And studies have shown that women who have menopause later in life were shown to have better longevity and improved health. So because of the increase in the life expectancy, we need to carefully plan for healthcare, and we also should urge our government to provide social services and pensions for our aging women. Okay. So why is it important? Why are we even here? Okay. Some of us, I'm menopausal, so if a few of us will be lucky that we will have mild symptoms. However, it is pegged that 70 to 80% of all women are affected by menopausal women. And as much as almost a third of these women will have moderate to severe symptoms. What do you mean by moderate to severe? Meaning because of the hot flushes, because of the sleeplessness, the mood swings, they are affected in their social living, in their family relationships, in their careers. Although the average duration of menopausal symptoms is around 7 years, in 33% of the time, women will experience symptoms even longer than 7 years. So there have been records of women even past 65 years old or 10 years after the onset of menopause, and they're still symptomatic. So if you see here in the diagram, these are just a few of the symptoms, signs that the women feel when they reach menopause or even hit perimenopause, okay? So this is a national survey done by the British Menopause Society. So these are the common. So what they showed was that British women commonly complain of vasomotor symptoms, almost 80%, okay? Followed by sleeplessness, joint pains, difficulty in concentrating. You see here, 50% of women complained that it had impacted their home life. And almost 50% also said that the symptoms were worse than they expected, okay? We are Asians, okay? So this is a nice study. So this is a randomized multi-country, 11 Asian countries. Philippines is included. Vietnam is included in this study. And they tried to survey the most common complaints of menopausal women in Asia. And if you see here, contrary to what the British feel, for us Asians, the most common complaint is body or joint aches and pains. So in the survey, 96% of Vietnamese women complained of that. So if you see that in your patient, do not like say that, oh, it's nothing. No, it's a valid complaint of menopausal women. And in this randomized trial also, they show that even giving the lowest dose of your menopausal hormone therapy in the form of conjugated equine estrogen and medroxyprogesterone acetate at a dose of 0.3 milligrams, it already alleviated or addressed those symptoms. Okay. More importantly, because most women will say, oh, it's okay. I can bear the hot flushes. I'm not really bothered. But we as obstetrician gynecologists, we as physicians, it's our responsibility to inform them of the more concerning long-term health consequences. So initially, they will just complain of the vasomotor symptoms, sleep disturbances. As they grow older, they experience the genitourinary syndrome of menopause, meaning recurrent urinary tract infections, sexual dysfunction, atrophic vaginitis, urinary incontinence. Those deteriorate the woman's quality of life, okay? Of course, we are less beautiful, our skins wrinkle, we lose the collagen, but more importantly are the long-term consequences, the risk for osteoporosis and osteoporosis-related fractures, sarcopenia, meaning muscle wasting as we age, even depression. So the depression is bidirectional. So studies have shown women who are menopausal have a higher risk of being depressed, and depression, and those depressed women also occur during menopause. There is also a risk for cognitive decline, even to the extreme extent of Alzheimer's disease. So we know that women who are in their menopausal are at a higher risk and even higher than men, okay? Cardiovascular disease, so when we lose that estrogen, the heart is not protected anymore. So we see the rise in our cholesterol when we hit menopause. The increase in the incidence of cancer is not really menopause related or not due to the loss of estrogen, but more age related. But nonetheless, it's still associated with menopause. And the overall increase in all-cause mortality. So this is what we should bring, or we should tell our patients. That's why we need to treat them or address their concerns. And again, more recent evidence is showing that the hot flush or vasomotor symptoms are not as benign or as mild as we seem they are. So studies are showing that if the patient has more increased frequency or severity of the hot flush, then she is also at an increased risk of cardiovascular disease, metabolic syndrome, even diabetes, even depression, and cognitive impairment. So what does this mean? So if your patient complains of the vasomotor symptoms, then you should closely monitor these patients, meaning monitor their blood pressure, cholesterol profile, the weight, so that because these patients may have a higher predisposition to cardiovascular and cardiometabolic syndrome. Okay, so with regard to the menopausal hormone therapy, where are we now? Why is this even a concern? So before that, we all know the Women's Health Initiative study, right? So before the WHI, I was still a fellow in training that time. Everybody was prescribing menopausal hormone therapy. And then when the WHI study came in 2003, it gave a scare. It gave a global scare to the patients and also to the doctors. That's why there was a drop in the estrogen therapy used by 45% and the combined hormone therapy by 20%, 22%. But we all know that hormone replacement therapy is still the best therapy to alleviate moderate to severe vasomotor symptoms and also to prevent osteoporotic-related fractures, okay? So now, the FDA recommends the use of menopausal hormone therapy at the lowest dose that will alleviate the symptoms and a shorter duration of time. And we do not give it to prevent coronary heart disease because that was what the aim of the World Health Initiative study was, right? So they disproved it. So we don't really give it so that the patient will not have a heart disease, but evidence shows that, yes, it may help delay the onset of cardiovascular disease, but that is not in the indication, okay? So at present, the indication is to improve the patient's quality of life by alleviating the vasomotor symptoms. And the use of the low-dose estrogen in various formulations and now the transdermal estradiol preparations are increasing because we want a safer route, right? Or transdermal, safer than oral, and lower dose, safer than the standard dose. Now, most HRT risks could be overcome by the use of the transdermal route of estradiol administration. So I would just like to review with you the 2022 North American Menopause Society statement indicating the 4 FDA-approved indications for menopausal hormone therapy use. So number 1 is to treat moderate to severe vasomotor symptoms. Second is to prevent osteoporosis in postmenopausal women. Number 3 is to treat hypoestrogenism caused by hypogonadism, bilateral oophorectomy, or premature ovarian insufficiency. This will be explained more in detail by our next speaker. So these are the population. This is the population of women that need MHT the most because they have their menopause younger. So they have the long-term consequences occurring at an earlier age. And lastly, to treat moderate to severe vulvovaginal symptoms, because if it's just mild, the recommendation is a vaginal estrogen, okay? So you give the systemic form when the vulvovaginal symptoms are moderate to severe. Okay, so when do we best give it? Okay, so that's why we should not be afraid. So if the woman is just recently menopausal, okay, within 10 years of her menopause, less than 60 years of age, relatively healthy, has no contraindications to hormone therapy, then the benefits outweigh the risk. So yes, we should give them. But if the patient is already 65, is past 10 years of her menopause, then it's more dangerous to give your MHT than not to give it because the risk of cardiovascular disease is higher, stroke and VTE and even dementia. Okay. So again, before giving any drug, we should know the indications and the contraindications. You will not give your systemic hormone therapy in patients with unexplained vaginal bleeding, meaning you have to assess first, okay, the reason with active liver disease, prior estrogen responsive cancer. So all breast cancer patients, even breast cancer survivors, cannot receive the hormone therapy. So we instead give them our alternative, our non-hormonal medical management. Patients with coronary heart disease, stroke, myocardial infarction, or venous thromboembolism, and patients with a personal or inherited high risk for thromboembolic disease. So these are just the different estradiol preparations. I am not familiar with what is available in your country. we focus our discussion on the transdermal preparation. Do you have the patch here? Do you have the transdermal patch? None. So I think both in the Philippines and Vietnam, what we have is the transdermal estradiol gel. Okay. So the transdermal gel, the transdermal route of delivery was started in the 1979. So this came initially in patches, okay, and later other preparations came about, like the emulsions, the spray, and the gel, okay. So what is the main advantage of this transdermal route versus the oral route? Like what Professor Tien mentioned is the bypass of the first pass hepatic and even GI metabolism. So when we bypass the first hepatic metabolism, we need a lower dose to have the active component compared to the oral form, which requires a higher doses. So it's in a way, it's safer. So in the transdermal route, the estradiol to estrone ratio is only 1:1, which is similar to the natural or to the physiologic site of premenopausal women, in contrast to the oral estrogen, which is the estrogen estradiol ratio is 5:1. Okay. So again, talking about the main advantages or benefits of transdermal estradiol. So there is no first pass metabolism. Thus, the same effect to alleviate the symptoms can be obtained at a lower dose. Second, there is a wider range of dose that you can give in contrast to the oral dose. It is less likely than the oral estrogen to cause side effects like the nausea. So there is nausea in the transdermal route. Okay. What is also nice is that we know that triglycerides are increased when you take the oral estrogen. But when you take the transdermal route, the triglycerides even decrease by almost 34%. And this is perhaps the reason why it's safe to give in women who are at high risk for cardiovascular disease. Studies have shown that there are also coagulation factor changes when you give the oral route compared to the transdermal route. Another advantage is that with oral estrogen, the sex hormone binding globulin is increased. So we know that the sex hormone binding globulin makes the estradiol less active, thus sort of having a lower libido with the oral form. But with the transdermal route, there is no lower libido. So again, this is advantageous because a lot of our menopausal women, although they will not actively voice it out, when you ask them, their sexual function is impaired or they have lower libido. Okay, the transdermal route does not have an increased stroke risk. It does not increase also the venous thromboembolism risk. Thus, it may be considered as first line for these patients who are at higher risk for these complications. Okay, so now let's discuss the evidence on the use of transdermal estrogen for vasomotor symptoms. So this is a systematic review and the network meta-analysis. So when you say network, they rate it. They categorize it as the best to the least. Okay, this is comparing two kinds of gels. Okay, Divigel and Estrogel. Okay, and the outcome assessed were the frequency and severity of hot flushes. So the preparations were as follows. So I don't know again if you have Divigel, but this is the estrogel that we commonly use. So it's the low dose, okay, and the standard dose, the 0.75 and 1.5. Okay. So if you see here in the forest plot, if you see we'll just concentrate on the estrogel. So estrogel, even at a low dose of 0.75 milligrams, was shown to lower the hot flush frequency more than the higher dose. And it was comparable in reducing the hot flush severity, whether you give the 0.75 or the 1.5 milligram dose. So what is the important thing about this data is that even at the lowest dose, you get the similar benefit, a lower frequency and severity of the hot flush. Okay. And with regards to continuation, sorry. Of course, when you use a drug, you also want the patient to continue using it, meaning it may be effective, but the adverse effects are severe that they stop using it. So again, if you look at this graph, you will see that if you use any line that crosses the middle means that it is not significant, okay? So even if you use the low dose, they do not report a higher incidence of adverse events in contrast to the higher dose, and neither the 0.75 or the 1.5 led to an increase in discontinuation of therapy. So it means that there is no risk for patients to discontinue estradiol. Okay. So this is now another systematic review and network meta-analysis, more recent, 2017. There were 47 randomized controlled trials included. Okay, and now they are comparing a lot of the therapies that were used for menopause. So this can be pharmacologic or hormonal in the form of the non-oral means a transdermal, okay, estrogen plus progestogen. There's also an oral combination, tibolone, raloxifene, your selective serotonin reuptake inhibitors. Your complementary, meaning isoflavones, the black cohosh, and even acupuncture were compared. And the outcome assessed were the relief of vasomotor symptoms. So if you see here, sorry if the slide is a bit blurred, okay? So if you see here with regards to the effectiveness of the drug in alleviating the vasomotor symptoms in the first, slide, okay, see here. So what is the most beneficial? It's anything that crosses the line is not. So the non-oral form, the combined estrogen plus progestogen is the most beneficial, okay? And with regards to discontinuation of the drug, the highest that would discontinue were those using tibolone, okay? And if we rank them, because this is a network meta-analysis, if you rank them, the estrogen plus the non-oral estrogen plus progesterone combination was ranked as #1 in being the best treatment for reducing the frequency of vasomotor symptoms. Okay. So this is what is nice about the network meta-analysis. Okay. So just to summarize that, was that the transdermal estrogen plus the progesterone was the most effective treatment for relief of vasomotor symptoms. It has the lower odds of discontinuing treatment, okay? The oral form is also effective, more effective than placebo, but inferior to the transdermal form. They also did the cost-effectiveness analysis of the hormone therapy being used for 5 years, and they found that the transdermal hormone therapy was more effective for relieving vasomotor symptoms and more cost-effective compared to the oral form. Okay? Okay. So in conclusion, for women who have not undergone hysterectomy, the transdermal estrogen plus the progestogen was the most effective treatment for vasomotor symptom relief and most cost-effective treatment as vasomotor increased in severity with lower discontinuation rates. Okay. Now, what about the effect of transdermal estrogen on the bones? Because like I mentioned, we can also use our transdermal estrogen to help prevent osteoporosis or delay osteoporosis and prevent osteoporosis-related fractures, okay? So this is a meta-analysis, again, of 9 trials. So out of the 9 trials, there were 6 randomized controlled trials, okay, involving 643 women who received transdermal estrogen, okay? And the outcomes assessed was the increase in the bone mineral density after 1 year and after 2 years of use. And what did the results show, okay? So the results show that after 1 year of use, okay, based on these trials, there was an increase of 3.4% in the bone mineral density and an increase of 3.7% after 2 years of use, okay? So based on this meta-analysis of 9 trials, it seems that the bone mineral density after 1 and 2 years of transdermal estrogen were higher than the baseline values. Thus, we can use this to protect the bone structure in postmenopausal women. Now, what about the possible effect or protection of our transdermal estrogen with regards to cardiovascular health? So this next few slides will delve more on the KEEPS trial or the Chronos Early Estrogen Prevention Study. So this trial emerged after the WH trial, okay? If you can remember, the WHI trial involved older women. That's why they found that there was an increased risk of stroke, VTE, and breast cancer, because these women, when enrolled in the study, already had pre-existing cardiovascular disease. So with the KEEPS trial, these women were relatively younger. So most of they were only 42 to 58 years of age. They were recently menopausal, meaning they were included in the trial if they have just been menopausal within 3 years, okay? They were excluded if they had a pre-existing coronary heart disease. So these are relatively healthy postmenopausal women. And what were they trying to study? They were trying to study the possible benefit if we give our MHT timely, meaning right after menopause in these healthy women. And how do we assess the cardiovascular protection? By measuring the carotid intima media thickness, okay? So this is a multi-center 4-year randomized trial, okay? There were 2 arms, so patients were given the oral conjugated equine estrogen treatment group at a lower dose. So not the standard 0.625, but at the 0.45 milligram dose. And there was another arm, a transdermal estradiol, but this is a patch of 50 milligrams. And both treatment groups were given micronized progesterone at 200 milligrams sequentially for 12 days each month, okay? So what were the results? So the results with regards to the primary outcome. So it had a neutral effect on the range in the carotid intima media thickness. However, there was a trend, although non-significant. So there was a benefit. There seemed to be a benefit in the reduction in the carotid coronary artery calcium with both oral and transdermal estradiol, okay? There was no bad effect on the blood pressure, meaning both forms did not cause an increase in blood pressure, and there were no severe adverse effects, meaning there was no incidence of venous thrombosis in both arms. They also did ancillary studies, meaning the first arm was about cardiovascular health, and then they had other studies from that, assessing relief of vasomotor symptoms, improvement in sleep, improvement in sexual function, bone mineral density, cognition, even skin wrinkling, and breast pain. So what were the results based on this randomized double-blind placebo trial? Was that there was reduction in the hot flushes and night sweats in both forms, okay? The improvement in sleep was also noted in both oral and transdermal estradiol. Sexual function had more improvement with the transdermal form compared to the oral form, like we said, right? Because it had no effect on the sex hormone binding globulin. There was also benefit. So the bone mineral density was maintained at the spine and the wrist in both forms. However, there were no significant effects noted, either oral or transdermal, on cognition, breast pain, or skin wrinkling. Okay. Now we discuss about the safety. So we know that transdermal estrogen is very beneficial. So it addresses the vasomotor symptoms. It improves sleep. It increases the libido. Okay, improves quality of life. Now we ask ourselves, how safe is it? Okay, so we discuss the fears of patients and doctors prescribing on the risk of venous thromboembolism. Okay, so again, this is a large case control study in UK because they have good record keeping on their primary care database, assessing the risk or the association of VTE with MHT users. Okay, so they gathered from their data link 80,000 plus women, okay, with a primary diagnosis of VTE between these years, and then matched to controls. Okay? So the results show that, of course, there was an increase in the VTE risk with the hormone users versus non-users. Okay? And the increase was noted both in the estrogen-only HRT and the combined estrogen-progesterone. As to the kind of estrogen, the lower risk was noted in the estrogen-only preparations than the combined estrogen. So this was also what was found in the WHI. That's why they surmised that the kind of progestogen is equally important, because in the estrogen-only arm, it had a lower VTE risk combined to the estrogen-progestogen arm. So they noted that the highest risk of venous thromboembolism was found in those who were given conjugated equine estrogen plus medroxyprogesterone as the progestogen, okay? And the lowest risk was those given estradiol with dydrogestogen. So in this database, there was not much micronized progestogen that was used, okay? So the transdermal preparation was not associated with any VTE risk. So we will see this in this forest plot. So if you see here, okay, like I said, anything that crosses 1 is not significant. Okay, so when we see the transdermal preparation, with whether we give the estradiol only transdermal or the combined estradiol, there is no increase in the risk of VTE. And if we give our transdermal hormone therapy, even if we give the ultra low dose or the low dose, 50 or more, less than or more than 50, this is a patch, there is also no significant increased risk in VTE. So it's safe if you ask if you are thinking of the VTE risk. Okay? Such that the different menopause societies, British Menopause Society, the International Menopause Society, the European Menopause and Andropause Society, the Royal College of OBGYNs, Australasian Menopause Society, and even the Philippine Society of Climacteric Medicine. We just launched our recent clinical practice guidelines on menopausal care. We support the statement that compared with women not on MHT, of course, there is an increased risk of venous thromboembolism with oral MHT, and that transdermal administration is unlikely to increase the risk of venous thrombosis. So this is a good option for patients who are afraid or who may have comorbidities or have risk for thromboembolic accidents. Okay. So again, the transdermal route should therefore be considered as the first choice of estradiol administration in women with related risk factors. So if your patient is diabetic, obese, had a history of heavy smoking, then this may be a better option, the transdermal route. Okay. Now, what about another scare, right? So some of us are afraid to prescribe because of the risk of breast cancer. So this is a 2019 publication in Lancet, okay? It is a meta-analysis on the incidence of breast cancer in menopausal hormone therapy users. So there were around 108,000 plus women who developed breast cancer at age 65, at mean age of age 65, and 51% used the MHT. The study population, the period of use was 10 years in current users and 7 years in past users. So this is a statement. We all know this, that all forms of menopausal hormone therapy, except the vaginal form, may be associated with an increased breast cancer risk. But is it that big? Okay, so both the oral and transdermal forms were shown to have an elevated breast cancer risk of 1.33 and 1.35 after 5 to 14 years of use. Okay, so again, if you look at this graph, okay, so this is the 1.33, 1.35 increased risk with oral and transdermal route. However, this was commented upon again by the collaborative group on hormonal factors in breast cancer. So this was again a joint statement by the British Menopause Society, the International Menopause Society, the EMAS, the RCOG, and the Australasian Menopause Society. They qualify that although there is a risk, the risk is small, okay? So it's like, and the risk is noted only after 5 years of use. So if the patient has been using the menopausal hormone therapy more than 5 years, there is an extra 1 case of breast cancer compared to non-users. And after 10 years of use, there is an extra 2 cases. So the absolute risk is not that great. And another limitation of this study is that a bulk of the one included in the study, there was one study that was included wherein after 4 months of the patients being on MHT, they already developed, some developed already breast cancer. So this was a limitation in that it may have increased the risk because you would not develop breast cancer in 4 months because of the hormone therapy, right? So it may be possible that the patients already had a pre-existing breast cancer tissues and then they developed into cancer. Another limitation of this meta-analysis of this study is that only a small number of women were on micronized progesterone. So there is now evidence showing that if you combine your estrogen with micronized progesterone, then this further lowers the risk of invasive breast cancer. Okay, so these were not included, and the WHI prolonged trial noted that there was no significant increase in the mortality because of the breast cancer. So meaning even if they're diagnosed with breast cancer, they were not at risk of dying earlier compared to those who had no hormone therapy because they were early diagnosed, they were screened regularly, and they were addressed early. Okay. So this is a systematic review of 19 studies. Like what I told you, if you combine estrogen with micronized progesterone, this is not associated with an increased risk of breast cancer for the first 5 years. And if you extend the use for more than 5 years, it again still results to a lower risk of breast cancer when you pair your estrogen with a micronized progesterone or dydrogesterone, compared to pairing it with a synthetic progestogen. Okay, and the short-term and long-term increased risk in breast cancer was only for the long-term use. Okay. So now we can also look at menopausal hormone therapy for prevention. Meaning, if we're looking at the big picture, all meta-analysis, systematic reviews are telling us that women who are on menopausal hormone therapy have a consistent 30% decrease in all-cause mortality with menopausal hormone therapy. So why? Because aside from the relief of the vasomotor symptoms, the menopausal hormone therapy also affords protection from osteoporosis. So we know that having a pelvic fracture and having surgery for a pelvic fracture can be fatal. Okay, it reduces menopausal symptoms and also improves overall quality of life. So how do we monitor women who we prescribe menopausal hormone therapy? So first, like I said, you have to assess the patient, risk assess. for metabolic conditions, cardiovascular conditions, and also risk for cancer, okay? And then you do your routine testing, you must do your mammography, your pap smear, and you may also do your transvaginal ultrasound. And the Endocrine Society recommends monitoring our patients who are on HRT for the first 1 to 3 months of therapy, then reevaluate them at 6 to 12 months, and then yearly or annually after that. Okay? So like I said, we are gearing towards menopausal hormone therapy as a means for prevention. Okay? So because some diseases such as coronary artery disease and osteoporosis are accelerated because of menopause, and others such as cancer are more age-related. So the onset of menopause sort of heralds an important opportunity for us to intervene, to do our screening, and to give treatment to enhance the woman's quality of life and prolong her life expectancy or enhance longevity. So the hormone therapy seems to be an important intervention both for quality of life and potentially reduce mortality. Okay. So looking at again at perimenopause, meaning perimenopause, meaning even if they have not hit menopause yet, we can already intervene. So as a means of prevention, we as healthcare providers should discuss, assess, and prescribe interventions to these menopausal women. Okay. So the prevention strategy is very important, more important in younger menopausal women. Those who have their menopause younger than 45, those who have premature ovarian insufficiency or POIs, because that is not physiologic. They lose their hormones less than 40 years of age. Those who we did surgery on, if you did a total hysterectomy with bilateral salpingo-oophorectomy for whatever indication at a young age, then again, you deprive the patient of her estrogen. That's why now, right, we don't remove ovaries, even if the patient is in her 40s, if there is no indication. We let the woman have her natural estrogen for as long as she can enjoy it, and then give our hormone replacement therapy when she hits menopause. Okay. So of course, first in the treatment is we advise lifestyle modification. So we tell our patient to have a good diet, okay? Exercise, stop smoking, and limit alcohol intake. We do our cardiometabolic surveillance minimum of every year, and maybe more frequently if the patient has risk factors for cardiovascular disease. We do our cancer screening, so we do our annual mammography. We start our colonoscopy. In the Philippines, we start it at age 45. I don't know when you start your colonoscopy, and do it every 10 years. We may do a baseline fecalysis, pap smear, HBV testing, and transvaginal ultrasound. And then lastly, as a form of prevention, we may consider using hormone replacement therapy. So a summary, menopausal hormone therapy significantly improves the quality of life of our symptomatic menopausal women. Transdermal estrogen is first-line treatment option for moderate to severe vasomotor symptoms, especially in women with risk factors for venous thromboembolism. The transdermal estrogen route has no increased VTE. The lowest dose, even the lowest dose of 0.75 milligrams, alleviates the vasomotor symptoms. It has a positive effect on the lipid profile. So we see that the triglycerides are decreased by as much as 34%. It improves sleep. It improves the mood. It improves sexual function, maintains bone mineral density and muscle mass. And combining your transdermal estradiol with your micronized progesterone does not increase the risk of breast cancer in the first 5 years of use. So I end you with this. I like this statement because gone are the days of aging women who are just left at home, right? Not traveling, in a wheelchair, and not having a physical activity. So now we see the modern menopausal woman. Like I said, I'm menopausal, who are, this is the new type of postmenopausal women. We are active in work and at home. We are independent in our choices and actions. Postmenopausal women are valuable members of the modern society. They have knowledge and skills accumulated through life experiences. Thus, we as primary care, as physicians should see these qualities as an opportunity and a resource to help them. Gamon, thank you very much for your kind attention.